Great, thank you very much. So, my talk will be about, as Anna said, about to complete an incomplete canal gem, and we'll try to go through this atypical scenario for the PPV. Actually, is not that rare as we could imagine. Is actually not uncommon to see patients with this atypical BPPV. Most of these the patients had typical BPPV. Then some other patients, those are the most tricky patients, do present from the beginning with this kind of exam that actually mimics something different. So we'll see during the talk. So first of all, I would like to thank my close colleagues that are Pasquale Malara from Switzerland and Salvatore Martellucci from Latina, Italy. Those are my close colleagues. I would say that this talk is shared by them, as most of the videos that you will see are actually videos from Pasquale and Salvo. So we together worked a lot on this topic, and so the things that I will show you today are actually that come from them, from their work as well. So we know that BPPV might be due to a canal lithiasis. In canal lithiasis, otoconia are free to float back and forth along the canal, leading to paroxysmal nystagmus, that is direction changing according to the position of the head with respect to gravity. We are seeing now a typical BPPV of the right posterior canal. So you could see that there was a transient paroxysmal nystagmus that is due to a transient movement of otoconia inside the canal, going from the upper part of the canal to the lower part of the canal. This is another typical canal lithiasis of the horizontal canal. You can see here that depending on the position of the head with respect to gravity, we can see that nystagmus goes from one direction to the other direction, so it reverses the direction, but it's typically paroxysmal. So it just lasts a few seconds that are the second needed by the canalids to go in one direction and in another direction, depending on the gravity vector and on the acceleration that we are imparting to the head of the patient. So this is the first scenario that it's the most, I would say, the most typical scenario. Then we might have cupulolithiasis. In cupulolithiasis, we have that otoconia. We have otoconia that adhere to the cupula of the affected canal. In this case, we have a posterior canal cupulolithiasis. You can see here that we bring the patient in the whole body test, and we can see now here a typical persistent upbeat nystagmus with a right torsional nystagmus. So it's typical of posterior canal BPPV, but if you can see now, it's persistent. It lasts a lot. And we can find also a neutral point where the cupula aligns to gravity. And then if we change again the position of the head according to gravity, we can see that now the nystagmus reverses. But it's a persistent reversion of nystagmus because the cupula is bent from one side or on the other side, depending on the position of the head. And since the cupula is overloaded, it will give a persistent direction change in nystagmus. This is another patient. This is an old patient with horizontal canal cupulolithiasis. In this case, it's a right horizontal canal cupulolithiasis. You can see here that after a while, we have a persistent left beating nystagmus, horizontal left beating nystagmus. It means that it's an apogeotropic, of course, nystagmus, since now the cupula of the right horizontal canal is bent toward the canal. So it's a stimulus that inhibits the afference of the right canal. Now we bring the patient in the contralateral position, and after a while, the nystagmus starts to reverse. And this is due to the fact that the cupula is overloaded, and now the cupola is bent toward the ampulla, so it's excitatory for the right horizontal canal. So now it's a persistent right beating nystagmus, but it's apogeotropic, of course, and it's definitely higher. It's definitely stronger. And in this position, when the patient has the position of the head slightly tilted toward the affected side, as in this case, slightly tilted toward the right, we have a null point because the cupola is aligned with the gravity vector. So we do not have any nystagmus. So in this case, we have cupular litholysis. But there is a third scenario. The third scenario is the canally jam. What is a canally jam? Canally jam might be complete or incomplete. It's due to the fact that an otolith clot, there are otoliths that aggregate in a clot, and this clot, probably due to a stenosis of the canal or a narrow tract of the canal where the canal is narrower, they get stuck in a position and they lead to a persistent endolymphatic flow that persistently bend the cupola in one direction or in the other direction, depending on several things, on gravity, probably on the last movement that otoconia were having just before getting entrapped. We can see here we have my friend Salvo with a patient with a typical horizontal canally jam, where you could see a typical persistent direction fixed nystagmus, depending irrespective to the position of the head compared to the gravity. And this is another patient with a posterior canally jam. In this case, there is a complete jam. So from the beginning, the patient starts with this spontaneous nystagmus. One of the most important things is that this kind of spontaneous nystagmus, and we will see a lot, can be modulated by gravity. And this is typical of a complete canally jam that can differentiate a spontaneous nystagmus due to a canally jam from a spontaneous nystagmus due to vestibular neuritis or central pathologies and other things, or Meniere's disease and so on. But complete canally jam are not that common. The most common condition are the incomplete canally jam. You can see here that in this case, the patient didn't have anything in the sitting position, but as soon as he gets the recumbent position, starts a persistent direction fixed positional nystagmus. You can see here again, we bring the patient back in the old pike position, and again there is a persistent downbeat nystagmus with left torsional components, and it might be due to a incomplete canally jam. It means that in this condition, this otoconial clot does not give a persistent deflection of the cupola from the beginning, but just in some position, probably it gets in a narrow tract of the canal, and in this condition, and in this just in this case, leads to a persistent deflection of the cupola. So it's a positional. We can say that is a positional jam. Okay, incomplete or positional jam. And this is very common, and this is probably the underlying pathomechanism of most of the anterior canal litholysis and apogeotropic posterior canal litholysis that we will see later. The first one who described the canal jam was Ginepple at the end of the 90s. This is one of his wonderful work, wonderful manuscripts, and he thought that canal jam could occur because there was an otolith migration from a wider to a narrower segment of the canal, and he identified three portions of the canal that could be probably responsible for a canal jam. At the outlet of the ampulla, where from the canal to the ampulla, where there's the passage from the canal to the ampulla, or at the bifurcation of the common crus, or between the ampulla wall and deflected cupola, not allowing to return into its narrow position. And according to Ginepple, it should be suspected a canal jam when a sudden conversion from a transient positional nystagmus to a persistent form which is thereafter unaffected by change of head position, as we saw. So it usually might occur as a complication of a canal repositioning maneuver when we have three signs that suggest many free particles, that is, a provocation of vertigo by minimal changes of position, severe positional nystagmus of long duration, and involvement of more than one canal. Actually, we can say that they are not that rare because this is a nice work. This is a nice paper where these colleagues from the US collected patients with refractory BPPV, and they submitted these patients to a surgical plug. And they scanned the part of the canal that was plugged, and they scanned with the electron microscope, and they found the otoconia and otolytic membrane fragments that were partially embedded in a gel of matrix rather than free-floating otoconia. So probably our opinion, our thoughts of BPPV, where we have free-floating otoconia running through a smooth wall of the canal, is not the correct idea that probably actually every patient has. So probably this complete or incomplete occlusion of the canal due to otoconial matter does not seem to be so unlikely to occur. And we can also see some papers. This is one of the few papers that we have in literature. It says that in some cases of refractory BPPV, we can find some filling defects within the semicircular canal on the 3D high resolution reconstruction on MRI. We can find sometimes this tiny filling defect on the canals affected by BPPV. So probably there are tiny stenosis on the canal that might facilitate the occurrence of canal jam, the blockage of a clot of canal inside the lumen of the affected canal. This is the first case described of horizontal canal jam complicating canal repositioning maneuver for horizontal canal BPPV. And in this case, it was described a canal jam that led to a persistent negative pressure on the cupola, leading to a persistent deflection of the cupola away from the ampulla. So it's an inhibition of a persistent inhibition of the afferent of the canal, so leading to a paretic, let's say, spontaneous nystagmus, with a positive bedside horizontal head impulse test that reversed, that normalized after canal repositioning maneuver. And it was from Michael von Breven, and these are other colleagues from South Korea that described another case of horizontal canal jam complicating wrong canal repositioning maneuver for geotropic horizontal canal BPPV. And in this case, there was probably a canal jam that led to a persistent positive pressure on the cupola, leading to a persistent deflection of the cupola toward the ampulla, so leading to a persistent excitation of the canal afferents, leading to an irritative nystagmus, let's say. And even in this case, there was abnormal head impulse that was reversible after canal repositioning maneuver. So we might have a continuous positive pressure or a continuous negative pressure, and it will depend on the gravity, on the position of the clot with respect to the ampulla. It might be due to which was the last movement of the otoliths before getting entrapped that led to a persistent flow of endolymph toward or away the ampulla. So there are several factors that might affect the clinical scenario of each canal jam. This is a very interesting paper from Professor Luis from Portugal. It was the first case where the video head impulse test was used to diagnose a canal jam. In this case, there was a selective lesion, a selective impairment of the VR gain at the video head impulse test for the affected canal in a patient with spontaneous nystagmus that's reversed after canal repositioning maneuver. So they hypothesized it was a canal jam. And they introduced a very interesting tool for the diagnosis of the canal gem, that is the video head impulse test. Video head impulse test is very useful because we know that it has a high frequency sampling camera with sensitivity overlapping scleroscope coil, and it gives precise measurements of the viewer gain of each of the 6 canals. And the target is, of course, the phasic irregular reference, the irregular reference, so the type 1 hair cells. And according to the device that we have, we might have this type of canalograms. This is the invented style, this is the interacoustic style, this is the NATO style, but all of them do have this canalogram that give us the information on the functional status in high frequency for each of the sinusoidal canals. And of course, we can use the remote camera as the one from Inventis, or we might have the head-mounted camera. But at the end, we have more or less the same data. So if the canal gem is assumed to alter endolymphatic flows leading to a persistent deflection of the cupola of the affected canal, and if the video head impulse test can precisely measure high frequency response of ocular reafferents for each simple canal, probably the video head impulse test could potentially provide useful clues to detect the involved canal in case of canal gem, complete or incomplete, and in case of atypical spontaneous nystagmus like vertical spontaneous nystagmus that is generally interpreted as a nystagmus due to a central involvement, or in case of atypical positional nystagmus, persistent downbeat positional nystagmus, it could probably contribute to a precise distinction between peripheral and central disorders. So it's very useful, in our opinion, the video head impulse test in this kind of atypical BPPV scenarios. So since then, a lot of papers have been written about the canal gem, because it's very, very interesting scenario that can help us understand some difference between typical acute vestibular loss and central vestibular disorders and peripheral vestibular disorders due to BPPV. This is our first report of a lady that had abrupt onset of acute vertigo with nausea. So she didn't have auditory symptoms, she had brain CT scan was normal. You can see here that she had a persistent horizontal nystagmus that was left weakly. So it was totally unaffected by head position changes. That was just a modulation of this spontaneous nystagmus due to gravity. She had also a bedside head impulse test that was positive on the right side. So our first diagnosis was right acute vestibular loss, acute unilateral vestibularity. And she underwent an instrumental workup, a deep instrumental workup. That was audiometry that was pretty fine. It was a caloric test that was actually impaired on the right side, so it was totally consistent with the right acute vestibular loss. But ocular and cervical vamps were symmetrical, and we didn't expect this symmetry, at least for the ocular vamps. You know that ocular vamps are expression of the utricle, so usually utricle is affected in an acute vestibular loss, at least of the superior branch. Vestibular neuritis involved in the superior branch. So we also made the video head impulse test, and video head impulse test gave us a selective lesion of the horizontal canal. How it comes? That an acute vestibular loss just involves the horizontal ocular reafferents. Might be a selective neuritis, could it be a selective ischemia of the arterial terminal branch that supplied the horizontal canal, or probably it was something different. It was an intralabyrinthine process, and we hypothesized this right horizontal canal pseudo-hyperreflexia due to a spontaneous canal gem inducing a selective plaque of the canal lumen. And this otolip clot that was entrapped within the membranous canal, in our opinion, could likely exert a continuous negative pressure on the cupula, leading to a persistent ampulophagal deflection of the cupula, leading to a paretic nystagmus, because it's continuous inhibition of this canal and preventing dynamic response of the right horizontal canal by blocking endolymphatic flows. So it likely result in a paretic spontaneous nystagmus, regardless of head position changes, and an impairment of the horizontal canal viewer gain for both low frequency caloric and high frequency at the video head impulse test. And it was interesting because after several head shakings, we saw the patient 2 days later, and you can see here how it converted. It converted in a typical BPPV, geotropic BPPV of the right horizontal canal. So in this case, the canal gem crumbled and eventually went in the non-equilibrium arm of the right horizontal canal, leading to a typical geotropic horizontal BPPV. Of course, we treated the patient with the Buffoni maneuver or whichever maneuver for canal reposition maneuver for the horizontal canal, and she was fine. So this was a typical case of a canal gem of the right horizontal canal mimicking a right acute unilateral vestibular loss. But the most interesting thing is that we repeated all the instrumental tests, and both low frequency and high frequency recovered. This is very interesting. So in this case, both low frequency and high frequency were affected by this continuous flow of endolymph and this paresis of this persistent deflection of the cupula that led to a paresis, an apparent paresis of the veer gain for the affected canal. This is another interesting case. This is my friend Pasquale Mara from Switzerland, dealing with a man with acute vertigo in the morning. He had a recent history consistent with positional vertigo. He didn't have auditory symptoms, brain CT scan was negative, neurological examination was unremarkable, and the bedside head impulse test, the clinical bedside horizontal head impulse test was positive on the right. So positive head impulse test on the right and paretic nystagmus, so left beating nystagmus. It is usually due to an acute unilateral vestibular loss. But you can see here, now my friend is using the master vibrator, and the master vibrator inhibits the spontaneous nystagmus. Look, now he's vibrating and it's inhibited, and it's not very typical. But look, now he's bringing the patient on the right side, and you can see here how the nystagmus reduces. And it's not very typical for a right acute unilateral vestibular loss. Usually, when we put the patient in the affected side, nystagmus increases. Now it decreases. So probably the clot is somewhere here that is affected by head position changes. Look, now we bring the patient on the contralateral side, and you can see how the nystagmus increases, because in this case there is the continuous negative pressure, and gravity increases this continuous negative pressure, so it adds up. The gravity vector adds to the negative pressure of the canal, of the clot on the canal. Another interesting thing is that on the right, at the supine head roll test, it transiently, just for a while, reverses, because now gravity goes against the continuous negative pressure. But just for a while. Then afterward, it starts again to go in a paretic, go toward the left. And again, we bring the patient on the left side. We bring the patient again on the left side, and it increases a lot. So it behaves very atypically compared to an acute unilateral vestibular loss, to an acute unilateral vestibulopathy, where we should have an increasing of paretic nystagmus when we bring the patient on the affected side. He also performed ocular vamps and cervical vamps, and they were normal, symmetrical. But the most interesting thing is that at the video impulse test, there was a severe selective lesion of the right horizontal canal, on the right side. So it's very, very, very consistent to a canal gem on the horizontal canal, leading to a persistent negative pressure on the cupula, as we say here. So probably there was a horizontal canal BP, a canal gem on the ampulary arm of the non-ampulary arm of the horizontal canal, leading to a persistent negative pressure on the cupula, leading to a persistent deflection of the cupula toward the canal, so inhibitory for the horizontal canal, leading to a left beating spontaneous nystagmus and paresis, selective paresis of the horizontal canal. And after head shakings, look what happens. Look what happens. After several head shakings, we can see now that in a few seconds, probably now is the moment when the clot crumbles. Look now, a paroxysmal right beating nystagmus, because now otoconia are here in the non-ampulary arm and they go toward the ampulla of the horizontal canal. So now the gem is scrambled. And now the patient has a typical BPPV of the non-ampulary arm of the horizontal canal on the right side. So Pasquale doesn't need to perform the supine hydro test to prove that it's a BPPV. He already knows. So we bring the patient in Buffoni maneuver. Look, and after the Buffoni maneuver, you can see here that nothing happens. There is nothing going on. So you can see here that no more nystagmus in upright position, in head pitch test, backward, head pitch test, forward. So it was a typical BPPV of the horizontal canal that was eventually converted in a canal gem, that it converted again in a typical BPPV of the right horizontal canal. You can see here now that even at the supine head test, nothing happens. And the most interesting thing is that after canal repositioning maneuver, the video head impulse test, the VIR gain for the horizontal canal normalized. Another interesting case, again from my friend Pasquale. In this case, there was acute vertigo of a lady, no auditory symptoms, brain CT scan was normal, neurological examination was unremarkable. But you can see here that it was a positive head impulse test on the left side with refixation saccades. So spontaneous left beating nystagmus with positive head impulse test on the same side. What is this? Is it central? Is it Meniere's disease in a typical, it's an acute phase of Meniere's disease? And look, now on the left or head bending, nystagmus recedes. Look, probably there is a canal gem that gave a positive pressure on the canal of the left side, and in that position, the gravity vector went against the positive pressure. And now, if we bring the patient in the other head bending of the upright head roll test, now gravity goes together with the positive pressure on the ampulla of the horizontal canal, so it adds up to the positive pressure, so the nystagmus increases, and it's what we have now. So you can see here how we can understand what's going on and the precise position of the canal gem by performing tiny movements of the head according to the minimum stimulus strategy. So according to the pitch plane and to the roll plane, even in the upright position. Now again, we bring the patient in backward head bending, and we can see here and still a left beating spontaneous nystagmus. Okay. Now Pasquale brings the patient in the supine position, and there's still a left beating spontaneous nystagmus. Now he brings the patient on the supine head roll test on the right side, and you can see here how nystagmus slightly increase, because in this position there's a positive pressure on the cupula that adds up with the gravity vector. And now he brings the patient on the opposite side, and now gravity goes against the positive pressure. So they delete each other. And so you can see now how nystagmus fades, recedes. And he brings it back again, the patient on the other side, and nystagmus comes back. So these are typical modulation of the canal gem in a typical in a patient with acute symptoms. He understood that it's a canal gem even because he already knows that there was a selective lesion of the horizontal canal via gain at the video hannibals test with normal cervical vamps and normal ocular vamps. He tries to disrupt this clot, but actually nothing happens because there is still a spontaneous nystagmus that goes toward the left side. He also used the mitral abrasion, but actually this is what we have in our hands to try to treat the patients. Of course, ocular vamps and cervical vamps were symmetrical, and there was a selective lesion of the left horizontal canal, of the left horizontal canal. And so the hypothetical mechanism was a continuous positive pressure on the cupula led by a canal gem that was probably in the ampullary arm of the horizontal canal. Why ampullary arm? Because, as we saw before, it followed the modulation of that spontaneous nystagmus that is typical of BPPV of the ampullary arm of the canal. So it was probably in the ampullary arm of the left horizontal canal. And after 48 hours, he suggested the patient to sleep on the affected side. And after 48 hours, you can see how it's converted. Look, now we have a tiny pseudo-spontaneous nystagmus toward the right side. You can see here, tiny right beating nystagmus. And this tiny right beating nystagmus is modulated by gravity. Actually, is changed by gravity. Now it's a direction change in nystagmus. You can see here how in head pitch test forward, it's right beating. Now it's right beating because otoconia are going toward the affected canal, toward the affected side. And again, on the right side, there's a geotropic nystagmus. At the upright headroll test, there's a geotropic nystagmus. I'm sorry that it didn't start here. We can try again to wait. Let's see if it is more clear even with this tiny animation here. So otoconia, after asking the patient to sleep on the left side, eventually fell here on the ampullary arm, on the non-ampullary arm of the left horizontal canal. So now, okay, now it goes. Now we bring the patient in the head pitch test forward, and otoconia are going toward the affected side, so there is a excitation of the horizontal afferents. Now otoconia, due to gravity, are going in the opposite direction, so we have a reversal of nystagmus. It's typical head pitch test for the horizontal canal BPPV of the in geotropic form, due to otoconia in the non-ampullary arm. Now, upright headroll test on the right side, and otoconia are going away from the affected cupula. So we have a right beating nystagmus. So it eventually converted in a typical geotropic form of horizontal canal BPPV. Now, at the supine headroll test, we will see the typical geotropic paroxysmal nystagmus on both sides. Now, at the CT supine test, there's a right beating nystagmus. Now, on the left side, after a while, there is a huge conversion of nystagmus, paroxysmal conversion of nystagmus. because otoconia are going toward the affected cupula on the left side. Okay, now we can see here how it has a typical crescendo decrescendo course. Now it starts and it becomes stronger. Of course, we need to shorten the video so we can show you all the typical course of the nystagmus. Then Pasquale puts the patient on the other side of the Panini-McClure test, supine hydrolysis test, and you can see here that now nystagmus converts. Of course, it's weaker on this side, so it's a typical geotropic BPPV of the left horizontal canal. And the most interesting thing is that the canal normalized. The canal of gain at video impulse test normalized after conversion in typical BPPV. But canal gem might also occur in the vertical canals, and it's very tricky because if this the canal gem occurs in vertical canals, it will give spontaneous nystagmus that are vertical torsional, but it's typical for central pathologies. But you can see here there's a girl with positional vertigo. She had a recent positional vertigo. She was initially seen in the emergency department, and she was diagnosed with the right posterior canal BPPV. She was suggested to perform a self-administered physical therapy, but she worsened. And you can see here a tiny downbeat nystagmus with the left torsional component. Tiny, very tiny. It's much more evident in the recumbent position. So it's a central downbeat nystagmus, or it's a peripheral spontaneous downbeat nystagmus. Of course, ocular ramps and cervical ramps are symmetrical, but look, there's a selective lesion of the right posterior canal that was the canal that was affected by BPPV a few days before. So the prothetical mechanism was a right posterior canal pseudo-hyperreflexia induced by canal gem, resulting in a selective and complete canal deficit. So this artery clot was completely entrapped within the membranous canal, and it could likely result in a continuous positive pressure. In this case, it was a positive pressure facilitated by gravity, resulting in a persistent ampulopetal deflection that for posterior canal is inhibition. It's not like horizontal canal that is an excitation. Now it's an inhibition of the canal, so leading to a downbeat nystagmus, downbeat controlational with torsional component toward the healthy side, preventing right posterior canal dynamics by blocking lymphatic flows and pulmonary responses. And we published this first case. So this condition could likely result in a spontaneous downbeat left torsional nystagmus, regardless of head position changes, and peer gain hyperfunction of the posterior canal, or the affected posterior canal, for both low and high frequency domain. Of course, low frequency domain for the posterior canal are very difficult to test, but we could imagine that if we had a chance to test the low frequency for the posterior canal affected, probably they were also impaired. And after Demis-Simon maneuver, we can see here, Pasquale is performing Demis-Simon maneuver, that it's maneuver for the aperture-tropic form of the posterior canal, for the variant of the posterior canal where otoconia are entrapped in an ampullary arc. You can see here that nystagmus fades. So probably it was a canal gem of the posterior canal that was affected. That could be managed by repositioning maneuver. You can see here now there was left a tiny downbeat nystagmus just in the position. But the most interesting thing is that the viewer gain for the affected canal fully recovered after repositioning maneuver. This is another lady that I saw a few months ago. You can see here that she had acute onset of unsteadiness. She didn't have BPPV. You can see here tiny downbeat nystagmus with left torsional components. We can see here how gravity could modulate the spontaneous nystagmus. We hypothesized in this case canal gem in the non-ampullary arm, leading to a persistent deflection of the cupula. we can see here that if we bring the patient in head pitch test forward, gravity counteracts the continuous positive pressure on the posterior canal, so nystagmus fades. And conversely, if we bring the patient in backward head pitch test, on the backward head pitch test, now gravity goes in the same direction of the positive pressure, and nystagmus increases. Spontaneous nystagmus increases. So this modulation of spontaneous nystagmus is very typical for this case of canal jam. And now we are vibrating the patient with a master vibrator just to see if something happens, but nothing happens. And we try to see if at the positioning, at the typical positioning maneuver for the posterior canal, something could happen, but actually nothing happened. Now I'm still vibrating to see if there was a strong conversion or something different. We also use the head shaking test. Of course, head shakings, master vibrators, you can see now the increase of spontaneous nystagmus with the head shakings. So head shakings continues repositioning from supine position to upright position, bring back the patient again, are the only things that we have in our hand to try to manage this kind of scenario. Of course, in this position, we have gravity that adds up to the persistent positive pressure on the posterior canal, so nystagmus increases. Now we bring the patient back in the upright position, and nystagmus starts to fade again. Now we bring the patient again in the Hall-Pike test on the left side. You can see here that there's no pretty much difference between right Hall-Pike test and left Hall-Pike test. In both Hall-Pike tests, we can have an increase of spontaneous nystagmus because there is gravity that acts in the same direction. So we try also to use some kind of bascule maneuver to see if something happens. Are basically maneuvers that helps us to unblock some conditions where probably otoconia are stuck somewhere in the posterior canal. We are performing continuous Semon maneuver from one side and reverse Semon maneuver on the same side. The importance is to align the head of the patient to the plane of the canal. So the head should be like this. But nothing happened. Apparently nothing happened. And of course, this was how she showed up at the bedside head impulse test. Look, nothing happens at the horizontal head impulse test. But if you see, when we go up, there's a tiny downward saccade for the posterior canal for the right posterior canal. Nothing happens on the left side, but look, there's a huge downward saccade on the RALP head impulse test when we perform the head impulse test for the right posterior canal. And in fact, there was a selective lesion of the right posterior canal even in this case. But the interesting thing is that 1 week later, after our bascule maneuver, we asked the patient to sleep on the healthy side, on the left side. Look, the spontaneous nystagmus is very reduced. It's very reduced. You can see here tiny downbeat nystagmus. It's not that evident as it was 1 week before, but look. Look, there is a huge unblock of the canal jam. Look, there's a downbeat nystagmus with right torsional component. That is usually the downbeat nystagmus that we have, the liberatory downbeat nystagmus that we have when we bring the patient back after a Semon maneuver or after an Epley maneuver, when we bring the patient back in the upright position. So probably otoconia fell. Otoconia, I bring back here. Otoconia went through the common cross and excitated ex vacuo the anterior canal, leading to a downbeat right torsional nystagmus. And in fact, after that huge nystagmus, you can see here nothing happens. Nothing happens. Everything is fine. So she doesn't have any nystagmus, any spontaneous nor positional nystagmus. Neither spontaneous nor positional nystagmus. So she's fine. She was managed by continuous repositioning maneuver, and also, of course, the Bascule maneuver that was performed 1 week before probably helped this gem to recover. And so our hypothetical pathomechanism is that a canal gem that was in the non-ampullary arm of the canal led to a persistent positive pressure on the cupula of the canal, leading to a persistent inhibition of the ampullary afferents of the posterior canal, and afterwards it recovered as otoconia probably crumbled and went into the common cross, leading to a significant ex vacuo activation of the ipsilesional anterior canal, leading to downbeat nystagmus, in huge downbeat nystagmus. And of course, after repositioning maneuver, the VR gain for the theta canal recovered again. Another case of my friend Pasquale, but it's different. Look how it's different. It's another posterior canal gem. This guy had a recent onset of positional vertigo, but we hypothesized that the canal gem was here, where Epley said at the passage between the ampulla and the canal, where probably there is a natural stenosis of the canal. We imagined that the canal gem was here, so it's different from the case that we just saw, because this downbeat nystagmus is differently modulated by gravity. Look, now in forward head bending, it's much more evident. So probably in this position, gravity adds up to the positive pressure, and the canal gem should be here, not here. Otherwise, we should have a reduction of the spontaneous nystagmus. And of course, when the patient is brought in the backward head bending on the head pitch test, now gravity counteracts the positive pressure of the clot toward the ampulla, so the spontaneous nystagmus recedes. It's smaller now. It's very smaller. Now it's almost absent. So this very nice modulation of the spontaneous nystagmus is typical again of this canal gem. And again, of course, the patient is now brought in the whole pike test, but I will rapidly go further. And of course, even in this case, ocular vamps were almost symmetrical, cervical vamps were symmetrical, and there was a selective lesion of the left posterior canal. So we had a left posterior canal gem, and my friend tried to use canal repositioning maneuver for refractory posterior canal BPPV. So he used master vibrators. He used also the rotatory chair to try to unblock this canal gem, and actually, this is what he found after 1 week. You can see here that there was no more spontaneous nystagmus, but there was probably a tiny downbeat nystagmus in this position. Tiny downbeat nystagmus with the left torsional component, while in this position there is a more evident upbeat nystagmus with right torsional component. So probably there are still some otoconia here in the ampullary arm of the posterior canal, leading to this positional nystagmus, even in the upright position. You can see how the minimum stimulus strategy, exploiting minimal head bendings from the upright position, are very interesting, are very useful in this case, because directly from the upright position you can understand if it's a typical spontaneous nystagmus due to an acute vestibular loss, or is something different, as it follows different lows. Okay, in whole pike position you can see now that it is a typical upbeat nystagmus. And of course, the rear gain of the affected canal recovered. Finally, we spoke about canal gem of the horizontal canal, canal gem of the posterior canal. This is a very interesting case because it's very rare. It's a canal gem probably of the anterior canal, as this patient had typical posterior canal BPPV on the left side, and symptoms progressively turned into continuous unsteadiness. She didn't have auditory symptoms, or she didn't have migraine, nothing. She had a brain MRI that was definitely normal, and she had this tiny upbeat nystagmus, spontaneous upbeat nystagmus that is typical for central pathologies. And this typical upbeat nystagmus is a little bit more evident in left distal pike test and also in right distal pike test. So is it central upbeat, spontaneous upbeat nystagmus, or it's the rare form or peripheral spontaneous upbeat nystagmus? She had almost normal ocular and cervical vamps, but the most interesting thing is that she exhibited a selective lesion of the left anterior canal rear gain. Left anterior canal rear gain, that is the anterior canal that is lesional to the posterior canal where she had a few weeks before a typical BPPV. So probably there is something going wrong in that side. We perform also a CT scan because we know that selective lesion impairment of the rear gain for an anterior canal might be due to an anterior canal dehiscence, but it was not the case. So we hypothesized a spontaneous pseudo-hyperreflexia due to a canal gem that was here, probably in the ampullary arm of the anterior canal, leading to a persistent deflection of the cupula toward the ampulla. So it's inhibitory for the superior canal, and inhibition of superior canal is an upbeat nystagmus. And after several Brand-Arrow exercise, we had again a conversion, a typical left posterior canal DPPV. We have the videos, but we have to shorten. We don't have time to show everything, and we have a normalization, almost normalization of the left anterior canal rear gain. So you can also you can see how many different scenarios we might have if we have a canal gem according to the position of the canal, according to the canal affected, according to the position of the clot within the canal. So that's I would like you to focus on the modulation of the spontaneous nystagmus that we can have, that we can have just bending the patient head on the head pitch test, on the pitch plane, on the roll plane, and also when we bring the patient in the supine position in the roll plane. But I said before that the most common form of canal gem are actually not a complete canal gem, where from the beginning we have a continuous flow of endolymph leading to a persistent deflection of the cupula, leading to a spontaneous nystagmus. The most common form of canal gem are actually the incomplete canal gem that we already said that are the gem that we obtain when we are in particular position, when we bring the patient in particular position, just like in the recumbent position. And these incomplete canal gem are responsible for the positional downbeat nystagmus. So we know that BPPV involving either the anterior canal or the non-pullary arm of the posterior canal can lead to positional downbeat nystagmus. In some cases, this positional downbeat nystagmus might not have a clear torsional component, but the most important thing is that in most of these cases, we might have a positional downbeat nystagmus with a persistent course, mimicking central positional downbeat nystagmus. We know that there are central positional downbeat nystagmus that are typical persistent. They're not paroxysmal. If we have a paroxysmal downbeat nystagmus when we bring the patient in the whole pipe test, this is for sure a BPPV. But when we have a persistent downbeat nystagmus, we are never sure. So differential diagnosis could be challenging in this case because we might have a central or peripheral downbeat nystagmus, positional downbeat nystagmus, and a more peripheral form. Is it an apogeotropic posterior canal BPPV or it's a contralesion anterior canal BPPV? Why? because position of downbeat nystagmus due to an apogeotropic form of the posterior canal, so due to an inhibition of the right posterior canal, is hardly distinguishable from a position of downbeat nystagmus due to an anterior canalithysis, due to an excitation of the contralateral leftward anterior canal, as nystagmus is generated from the contraction of the same pair of core muscles. We can see some cases. This is a left anterior canal BPPV, So when we bring the patient in the Holpike test or at the supine head, at the straight head angle position, we have a movement, an ampulofocal deflection, an ampulofocal movement of otoconia. They go away from the ampulla, so we have an ampulofocal deflection, so we have an excitation of the left anterior canal, and an excitation of the left anterior canal is a position of downbeat nystagmus with left torsional component. But the same position of downbeat nystagmus with left torsional component might be obtained if we have otoconia that settle in the non-ampullary arm of the right posterior canal, so the contralateral posterior canal. Because in this case, when we bring the patient in the distal pike or the straight angle position, we bring this otoconia toward the ampulla of the right posterior canal, that it's inhibitory for the right posterior canal. So we have a position of downbeat nystagmus with left torsional component. So you can see here that these two nystagmus are hardly distinguishable. We can see this case. Look, a downbeat nystagmus with the left torsional component. You can see here that nystagmus is persistent. It's not paroxysmal. This is persistent. It's not very easy to understand how it might be persistent if there are otoconia free to float. So probably in this case, otoconia are not free to float. In this case, otoconia are not completely jammed from the beginning, but they are going to be jammed. They go to be jammed when we bring the patient in the downbeat, in the spine, in the straight angle position or the Holpike test. So how we can distinguish these two forms? This is another case similar. This is another case. One of the method that we have to see if that's right posterior canal BPV, right apogeotropic posterior canal BPV, or a contralateral anterior canal BPV, is to see what happens if we start to perform repositioning maneuver. So I usually use this school maneuver that is basically continuous Simon and reverse Simon again along the canal plane. The plane, of course, is the RALP, is the LARP, left anterior, right posterior, or left anterior. We don't know which are the cases, but look, after a few bascule, now we have a typical conversion in a BPPV of the right posterior canal. So it was a right apogeotropic form of the posterior canal. But yes, this is the typical. This is one of the most important paper about the apogeotropic posterior canal BPPV of leading to a persistent downbeat nystagmus. And our colleagues from Florence, they say that they first hypothesized that probably an incomplete canal jam, also called positional jam or transient jam, could be the underlying pathomechanism. So if the video head impulse test can precisely measure high frequency response of ampullary afferents for each single canal, and if video head impulse test could provide useful clues to detect the involved canal if video head impulse test can precisely measure high frequency response of ampullary afferents for each single canal, probably video head impulse test could provide useful clues to detect the involved canal in BPPV with persistent positional downbeat nystagmus. So non-ampullary arm posterior canal BPPV or anterior canal BPPV. And it could potentially provide a precise distinction between peripheral and central BPPV, because we know that in typical benign paroxysmal positional vertigo, where otoconia are free to float, the video gain is rarely impaired. We do not have significant alteration for the posterior canal involved at the video impulse test in most cases, as free-floating particles do not alter high-frequency response. But if we have, as already theorized, if we had this incomplete canal gem leading to a persistent positional downbeat nystagmus, so a positional gem, we might have this kind of so-called low-pass filter. We can say that's low-pass filter. Why? Because this kind of incomplete gem allows the cupola to be activated by low-frequency stimuli that are the otoconia that shifts from one place to the other place of the non-ampulary arm of the posterior canal or the anterior canal, but they impede the ampulary receptor to respond to high-frequency inputs that are the head impulses. So we can detect the involved canal if we have a persistent positional downbeat nystagmus. So this is a case, this is Pasquale again, with a lady with positional vertigo, but you can see here that this is not a typical paroxysmal upbeat nystagmus in the right distal pike test with paroxysmal course, with crescendo decrescendo course. So this is a persistent downbeat nystagmus with right torsional component. So is it a right anterior canal BPPV or left apogeotropic posterior canal BPPV, or is it central? So we can measure the otoliths receptors. Everything is fine. But if we measure the canal function in high frequency, we will find a slight reduction of the affected canal. You can see here that it's not that reduced as we have in the complete gem. There is a tiny reduction of the affected canal, but it's very, very evident because we also have this huge corrective saccades. And of course, after repositioning maneuver, she converted in a typical BPPV of the posterior canal of the left side. So it was a left apogeotropic BPPV, where otoconia were stuck in the non-ampulary arm of the posterior canal. And after the positioning maneuver, after converting this non-ampulary arm posterior canal BPPV of the left side in a typical ampulary posterior canal BPPV of the left side, you can see here how we had a normalization of the posterior canal viewer gain. You can see here again the huge downbeat nystagmus due to important activation of the ex vacuo of the ipsilesional anterior canal. This is another interesting case of a patient with positional vertigo, but in this case, you can see here we do not have a typical paroxysmal nystagmus. We have a persistent downbeat nystagmus again with tiny left torsional components. So in this case, is it central, or if it's peripheral, is right apogeotropic posterior canal BPPV, or it's left anterior canal BPPV? We do not know. So we can measure with the video head impulse test what happens. You can see here that I performed a Jacobino maneuver because I knew that it was an anterior canal. Why? Because ocular vamps and cervical vamp were symmetrical, but there was a tiny reduction of the left anterior canal at the video head impulse test. So we performed a Jacobino maneuver, and everything, after a few Jacobino maneuver, everything recovered. So we have a normalization of the left anterior canal viewer gain. The video head impulse test was already tested in patients with positional downbeat nystagmus, and it was one of the first paper by Professor Perez in 2014, and he studied 12 patients with anterior canal BPPV with positional downbeat nystagmus. All patients exhibited a positional downbeat nystagmus with torsional component. The mean viewer gain was within normal limits for all the 6 semicircular canals, according to their measurements. But if we look at the inclusion criteria, they just included all patients with nystagmus that exhibited a crescendo-decrescendo pattern. It means that probably otoconia were free to float along the canal, and they were not leading to a positional gem. They were just free to float, and the mean duration of the nystagmus was less than 1 minute. It means that it was a transient nystagmus, not a persistent nystagmus. So of course they didn't find any difference of the viewer gain for the canal. What we found is something different, because we made a multicentric prospective study. We involved almost 60 patients with peripheral positional downbeat nystagmus, and we performed video and impulse tests before and after repositioning maneuver, after symptoms receding or transformation in typical EPP variants. And we found that most of the cases were apogeotropic posterior canal EPPV. And we found that in most cases, nystagmus was persistent. It means that it was longer than 3 minutes. It didn't show up with a typical crescendo-decrescendo pattern, but it was persistent, with a significant prevalence among apogeotropic posterior canal EPPV. And the interesting thing is that the visual gain of the affected canal was impaired in 72% of patients, considering all the patients. But if we consider just only patients with a persistent positional downbeat nystagmus, the visual gain was affected in almost 90% of patients, while considering patients with paroxysmal positional downbeat nystagmus, where probably otoconia were free to float, the sensitivity dropped to 25-26%, of course, because if they are free to float, they probably do not alter high-frequency dynamics. And the visual gain of the affected canal was significantly more impaired in case with persistent positional downbeat nystagmus compared to the one with paroxysmal positional downbeat nystagmus. And of course, the visual gain of the affected canal was significantly more impaired in those cases with a spontaneous downbeat nystagmus, so probably where we had a complete gem in those cases. And we also saw that presenting impairment of the visual gain for the affected canal in all cases normalized, so that is the canal affected before and after repositioning maneuver. And we found that after symptoms receding or conversion into typical BPB4, there was a normalization in all cases of the visual gain. So confirming there was a strong relationship between canal epithesis, this incomplete gem, and altered cupular dynamics. And we also found that also the paired contralateral canal on the opposite side. So if it's a posterior canal, this is the contralesional anterior canal, or if it was an anterior canal, this is a contralesional posterior canal. The visual gain values for the contralateral vertical canal that is functionally coupled with the involved canal significantly improved after canal repositioning maneuver. There was a significant improvement also for the other canals. This is probably due to a peripheral phenomenon. So probably there was a functional loss of the push-pull mechanism that could likely explain this phenomenon among cases with resonance of BPPV. Or it might be due to central compensation, something like cerebellar clamping, that likely explains the reduced visual gain values also in the contralateral per canal in those patients with long-lasting symptoms. But it was very, very closely related to this phenomenon. We can find some patients with visual fluctuation in BPPV depending on the position of the clot, of the position of debris. You can see here a young lady with recurrence of positional vertigo and nausea that progressively turned in chronic vesicular. She has a history of recurrent BPPV treated elsewhere. She also had an disabling pulsatile tinnitus on the right side. And she showed up with nothing. She didn't have a spontaneous nystagmus, but she had a typical positional downbeat nystagmus. You can see here a typical positional downbeat nystagmus with tiny left torsional components. It's persistent. You can see here that there is no crescendo-decrescendo pattern. There is just a persistent downbeat nystagmus. And we found her with this tiny reduction of the visual gain for the right posterior canal. So hypothesized that debris were partially entrapped in the nonpulmonary arm of the right posterior canal, resulting not in a spontaneous nystagmus, but in a persistent positional downbeat nystagmus, persistent positional downbeat nystagmus with slight high-frequency visual gain improved. In fact, we tried to perform Simon maneuver. Simon maneuver were designed by our colleagues Rudi Pecci from Florence to treat the apogeotropic form of posterior canal. But something went wrong because probably I performed it in a correct way. This is basically the second part of the Simon maneuver for the right posterior canal. But I made it wrong because I was very, very slow when bringing the patient back. This should be done briskly, not that slow. And in fact, after 3 days, she had persistent symptoms, but I found a typical posterior canal BPPV. This is a typical posterior canal BPPV with paroxysmal course with the crescendo pattern. And so probably otoconia were stuck there, and they eventually fell in the pulmonary arm of the canal. So I performed a Epley maneuver. The veer gain was normalized because now otoconia are free to float along the canal, and debris were free to move back and forth along the pulmonary arm of the canal without impacting on the high-frequency veer dynamics. So the veer gain was slightly affected before when we have a persistent position of the albino nystagmus. Now in this phase of this lithiasis, when we have a paroxysmal nystagmus typical of BPPV, now veer gain recovered. So we performed Epley maneuver, but after 5 days, she had a severe worsening of symptoms with the onset of disabling dizziness, something like ataxia. Look, she has a tiny albino nystagmus with left torsional component. It's a spontaneous nystagmus. It's a spontaneous nystagmus that is much more evident in this straight head hanging position. You can see here that she has this spontaneous nystagmus with, it's not very easy to understand which is the torsional component. But the most interesting thing is that in this stage of the disease, she has a severe reducement of the veer gain. So probably now she had a complete jam that leads to a spontaneous nystagmus due to a persistent inhibition of the afferents of the posterior canal. So in this case, debris failed to return with the Epley maneuver and were completely blocked within a narrow portion of the posterior non-pulmonary arm, in the non-pulmonary arm of the posterior canal, plugging the canal, completely plugging the canal, so severely impairing veer dynamics by exerting a continuous positive pressure on the cupula, inhibiting the posterior canal. And so we perform Simon maneuver. We perform demi-Simon maneuver very briskly. I will fastly go because we are losing time. And after 4 days, we have a symptoms resolution. Nothing happens. She doesn't have nor spontaneous, neither spontaneous nor positional nystagmus. Look, everything is fine. And she is fine. And we had a complete restoration of the veer gain of the affected canal. So as you could see, we had a fluctuation of the veer gain of the affected canal depending on the position of otoconia, how and where otoconia are disposed within the canal. So in this case, otoconia eventually fell in the uterus. We're going to the end of this talk. Some kind of patients with spontaneous reversal positional nystagmus might have this incomplete jam. Look, she's a lady with a typical paroxysmal nystagmus for the right side. Look. But after a while, this transient paroxysmal nystagmus with a typical crescendo course this is a typical posterior canal BPPV, let's say. She has a recurrence of BPPV. She has a multiple sclerosis. So I could also imagine that we could have some mimic. We could have some positional nystagmus that was mimicking, but she has a typical posterior canal BPPV. Okay, and I treated her with Epley maneuver. She had the normal veer gain for the affected canal. This is the posterior canal on the right side. In this case, we have otoconia that are free to move back and forth along the ampullary arm, so we do not have any impact on the high-frequency VR dynamics of the affected canal. And when you bring the patient in the opaque position, we have that free-floating debris in the ampullary arm of the canal move away from the ampulla, resulting in a transient excitation of the posterior canal reference and in paroxysmal upbeat right torsional nystagmus. That it is the typical nystagmus of the BPPV for the right posterior canal. But after 5 days, she said that she had persistence of symptoms and she had a tiny reduction of the VR gain for the posterior canal. Look what we found. We brought the patient back again in the distal pike position, and we had a transient excitation of the posterior canal reference. Look, so I suppose it was just a persistence of BPPV, of typical ampullary arm BPPV. But look what happens now. Why should she have this reduction of the VR gain? Look. After the transient paroxysmal upbeat nystagmus, she has a persistent downbeat nystagmus. So she has a spontaneous reversal of this positional nystagmus. She's always in the same position. So the first phase, she had a typical paroxysmal nystagmus, and then she has a spontaneous reversal of nystagmus with persistent positional downbeat nystagmus and left torsional components. So we perform again Epley maneuver. So we hypothesized that in this case, not all otoconia went away, but some otoconia eventually got stuck in this position. So we hypothesized that there are 2 separate groups of otoconia. The first group is in the ampullary arm, and in this position, debris are free to move back and forth along the ampullary arm of the canal without impacting high-frequency VR dynamics. And the second is the clot that is partially entrapped in the non-ampullary arm. So in this position, in the non-ampullary arm, the canal. And if we bring the patient in this position, if we bring the patient in the opaque position, in the opaque test, we have what? In provoking position, we have in the first phase, we have the movement of free floating debris that goes away from the ampulla, leading to transient excitation of the posterior canal reference and in paroxysmal upbeat right torsional nystagmus. And after they went in this position, starts working the incomplete canal jam. And in this position, this partially entrapped debris in the non-ampullary arm of the canal move toward the ampulla and block the posterior canal lumen, resulting in an incomplete or positional canal jam, and in a persistent positional downbeat nystagmus with controlational torsional components. So this is why some of the patients with spontaneous reversal of positional nystagmus do have a reducement of the VR gain for the affected canal. After 3 days, we had a normalization of the posterior canal VR gain, and in fact, she was free. Her posterior canal was free. But we found what? Interestingly, we found a geotropic nystagmus on the horizontal canal. So horizontal canal BPPV. So probably you can see here I go forward, otherwise I'll be late. Okay, now on the right side at the supine head roll test, there is a right beta nystagmus with paroxysmal course. So horizontal paroxysmal direction change in geotropic nystagmus due to the fact that free floating debris in the non-ampullary arm of the right horizontal canal move away from the ampulla, resulting in transient activation of the horizontal canal reference and paroxysmal geotropic nystagmus. So probably this clot switched from the right posterior canal to the non-ampullary arm of the right horizontal canal, leading to a geotropic horizontal canal BPPV. But in this case, there is no impact on the VR gain of the affected canal, because now otoconia are free to float. So you can see this strict relationship between what we find during positioning maneuver, and the viewer gain of the canal effect. So we're going to the conclusion. So we have in canal lithiasis, the typical canal lithiasis, we have transient paroxysmal nystagmus in position test, reversing depending on the position of the head according to gravity. The video head impulse test generally is normal because free-floating debris move back and forth within the membranous canals, and low frequency and high frequency are preserved because debris are free to move in both directions along the membranous canal. So we have a normal viewer gain for the affected canal. In case of incomplete, or we can say positional or transient canal jam, we usually have a persistent position damping nystagmus in both Dixell-Pike test and in the straight head angle position, rarely reversing while right. The debris are partially entrapped in an outer tract of the membranous canal, usually, or in the portion of the posterior canal close to the common cross, or in some stenosis of the anterior canal. And the viewer gain of the affected canal is slightly reduced because low frequency are probably preserved, because debris, even if they are partially blocked, are allowed to slowly shift toward the cupola or in the opposite direction in Dixell-Pike position and in straight head angle position, while high frequency dynamics are reduced as particles likely impede high frequency flows, dampening response to head impulse, so behaving as a low pass filter. And the last scenario is the complete canal jam, where we have an autolytic clot that is completely entrapped within another tract of the membranous canal, entering plugging the canal lumen from the beginning. So we have a persistent deflection of the cupola toward or away from the ampulla. So we have a spontaneous nystagmus that is slightly increased in position in test. We can say that it is modulated by gravity, and the viewer gain of the viewer impulse test of the affected canal is markedly reduced, and lymphatic flows and the lymphatic dynamics, both in low frequency and in high frequency, are impaired because there is a continuous lymphatic pressure generated, leading to a constant cupola deflection. So it will lead to important reduction of the viewer gain for the affected canal. So I'm going to conclude my talk. So I really would like to thank all of you. I would like to thank, in particular, my friends Salvo Castellucci from Latina, Pasquale Malaro from Switzerland, as they are actually co-authors of this talk. And I also would like to thank the VIS, that it's the Society of Vestibular Medicine from Italy, the society I belong to, and also AVISA, that it's Audiovestibular International Science Academy, that is head by Professor Mohammed Al-Fargab, that I really warmly like to thank because of his active involvement in spreading knowledge.